traducción simultánea y cuando ya empiece la conferencia, los que quieran escuchar la conferencia en español, en su pantalla abajo hay una clave que dice español. Y cuando ya empiece la conferencia, porque se oye un eco. No sé qué será. Bueno, listo, vamos comenzando entonces.
¿Listo? ¿Empezamos?
Listo, voy entonces a saludar. Buenas noches para todos. La Asociación Colombiana de Ginecólogos, Oncólogos y su Junta Directiva les da un saludo muy especial a todos los ginecólogos, oncólogos clínicos y patólogos que nos acompañan esta noche. Vamos continuando con nuestros webinars de los miércoles y les recuerdo que para este mes de octubre y para noviembre tendremos dos conferencistas muy importantes, patólogas ginecólogas de Estados Unidos. Para hoy tenemos el tema de Her-2 en carcinomas serosos uterinos. Nos acompaña la doctora Natalie Banet, que es especialista en patología ginecológica y que vive actualmente en la ciudad de Cleveland. Recuerden que, aunque la doctora Banet sabe hablar español, su conferencia se dará en inglés. En la parte de su pantalla, abajo, hay un botoncito que dice español. Los que quieran escuchar la conferencia con su traducción, le dan clic al botón que dice español y oprimen donde dice inglés. Ahí les van a traducir de inglés a español. Los que quieran seguir escuchando la conferencia en inglés no tienen que hacer ningún cambio en su pantalla. Estamos muy contentos. Hoy nos acompaña la doctora Angélica Fletcher, ginecóloga oncóloga, quien será la moderadora del evento y hará la presentación de la doctora Natalie Banet. Recuerden que debemos mantener las cámaras apagadas y el micrófono apagado. Y nuevamente les recuerdo, los que quieran escuchar la conferencia en su traducción para escucharla en español, le dan clic al botón abajo que dice español y luego le dan clic al botón que dice inglés y ahí escucharán directamente a la traductora. Los que quieran escuchar la conferencia en inglés no tienen que hacer ningún cambio. Muy honrados de estar con ustedes. Y doctora Natalie Banet, nuevamente, muchas gracias por acompañarnos en el día de hoy. Angélica, tienes la palabra.
Okay, so we're starting in English. Welcome, everyone. Thank you for being connected today. As Dr. Lucrecia said, the Colombian Association of Gynecology and Oncology has prepared for us a wonderful event with a very special guest, Dr. Natalie Banet. Dr. Banet is a pathologist who specializes in gynecological and cytopathology. She recently began working at the Cleveland Clinic in Cleveland, Ohio. She received her medical degree from the University of Louisville in Kentucky and completed her residency training in anatomic and clinical pathology at the University of North Carolina Hospitals, followed by fellowship training at the Johns Hopkins Hospital in Gynecological and Cytopathology, Maryland in the USA. She has worked in community practice in Denver, Colorado, and also in academic pathology at Women and Infants Hospital and Brown Medical School. Dr. Banet has published scholarly works in the area of gynecological and cytopathology and has a special interest in target therapies and diagnostics, cervical cancer, and ovarian cancer as well. She also is involved in educational efforts which aim to increase equity and diversity within her field. And she is the director of the International Society of Gynecological Pathologists Journal Club, as well as a member of the Life Educational Working Group of the same society. And she has received teaching awards for her efforts, most recently including the Dean's Excellence in Teaching Award from the Warren Alpert Medical School of the Brown University. So it is an honor to have her here with us. Thank you, Dr. Banet. Today she's going to talk about a very important and very current topic, which is Her-2 in uterine serous carcinoma. So welcome all, and welcome Dr. Banet, and the mic is all yours.
Thank you so much for having me. I appreciate your generous introduction, and I appreciate the opportunity to speak with your society. So I don't think any further introduction of myself is needed after that lovely intro, so I'll just go ahead and get started. Regarding my talk this evening, I have no relevant or ongoing financial relationships to disclose, but regarding my research discussed in this presentation, funding was provided to facilitate this research from Genentech. So today I'll talk about, first, I will give a brief overview of endometrial cancer, including classification schemes with an emphasis on uterine serous carcinoma. We will review histologic and clinical features. Then we'll pivot to a discussion of Her-2, including its function, and a brief recap of the history of Her-2 as it relates to uterine serous carcinoma. I will then summarize a recent study that I published with my colleagues and finish with a recap of where we stand in 2021 and give recommendations when possible based on what we know. So endometrial cancer is a commonly diagnosed malignancy and a common cause of cancer death in the United States. Its precise place in the statistics varies by countries and year, although the highest incidence is noted in North America and Northern Europe. So this is taken from the SEER cancer database, which is the NIH's surveillance, epidemiology, and end results program, which estimates the cancer diagnoses. And uterine cancer is the ninth most commonly diagnosed malignancy in female patients. While it is anticipated that approximately 65,000 cases were diagnosed in 2020, the survival rate was high at about 80%. But this takes all endometrial cancers as one homogeneous group. For example, uterine serous carcinoma accounts for about 10% of all endometrial cancer, but carries a very poor prognosis with a 5-year survival rate as low as 55%. This is a separate resource which shows you the outsized mortality of serous carcinoma. So the diagnosed cases are noted in the top graph in the black portion at about 10%, whereas the mortality is almost 40% when you take all endometrial cancers as one group. And this is opposed to grade 1 and grade 2 endometrioid adenocarcinomas, which account for almost 3/4 of diagnosed cases, but about 1/4 of the mortality. So now we'll pivot to talk about classification schemes for endometrial cancers. There are really two models that I'll cover today, the type 1 and type 2 model, and then we'll cover the molecular classification model. So the type 1 versus type 2 model posited that there are two primary pathways for endometrial carcinomas with distinct precursors, typical patient populations, and resulting common histologic subtypes. This is an infographic which depicts the differences between these two pathways. So the type 1 tumors are shown on the left. And if you start with normal endometrium in a background of unopposed estrogen in both pre and postmenopausal patients, and in some patients with an increased BMI, you can develop endometrial hyperplasia, which is now called atypical hyperplasia, or we think that is the precursor lesion. And the prototypical type 1 tumor was endometrioid adenocarcinoma. And these tumors tended to be characterized by PTEN mutations, microsatellite instability, and KRAS mutations. They tended to be lower grade, lower stage at presentation, and have a better prognosis. And this was opposed to the type 2 tumors, which, if you start with normal endometrium, tended to arise in postmenopausal patients and were not related to BMI. And the precursor lesion for these lesions was in a background of atrophic endometrium. You have a lesion called serous endometrial intraepithelial carcinoma, or what I will call from now on SEIC. And the prototypical type 2 tumor was serous carcinoma. And these tended to be characterized by P53 mutations. They had a higher grade, greater likelihood of advanced stage, greater likelihood of having LVI, and a worse prognosis. While this historical system of classification has been useful, substantial heterogeneity within and overlap between type 1 and type 2 cancers is now recognized. And so this is the molecular model. It really arose from this paper, which came out or titled Integrated Genomic Characterization of Endometrial Carcinoma, which was published in Nature in 2013. So what they did in this paper was they took 373 endometrial cancers, 307 of which were endometrioid and 66 were serous. And using a combination of whole exome and whole genome sequencing and copy number analysis, unsupervised hierarchical clustering grouped the tumors into 4 groups. So these are the names of the 4 groups. They were, and they had prognostically distinct categories. So these were POL-E ultramutated, microsatellite unstable or hypermutated, copy number low, and copy number high. And this is a graphic from the paper. And you can see those 4 types at the top. So you have the POL-E or ultramutated, the MSI hypermutated, the copy number low, which was also called endometrioid, and then the copy number high, which was also called serous-like. And this is the mutational frequencies plotted for each tumor. And I just wanted to highlight, you can see that commonly the P10 mutations were noted in the first 3 tumor types, but not as commonly in the copy number high or serous-like, whereas P53 mutations were much less common in the other subgroups. And in the interest of talking about serous carcinoma, we're going to focus on this, that the P53 mutations were common in the serous-like. Regarding the histotypes of the other groups, this is an ongoing and explosive area of research, but POL-E ultramutated tumors are frequently high-grade endometrioid histology and are characterized by few copy number alterations. MSI high and hypermutated tumors include Lynch syndrome cancers, as well as tumors that have loss of MMR through hypermethylation of one of the MMR proteins, and are about 25 to 30% of endometrial carcinomas. And the copy number low tended to be endometrioid endocarcinomas. Serous carcinoma of the endometrium almost exclusively fell into the copy number high category, as did most carcinosarcomas. Clear cell carcinomas, which are rather rare, falls into multiple different categories. And overall, this system has given insights into the molecular features of endometrial carcinoma, but has proven difficult for most practicing pathologists to implement in clinical scenarios due to cost. Though some centers have implemented a testing algorithm which combines selected mutational testing and IHC to reapproximate this. I would say, at least in the United States now, it seems like this is not widely practiced for routine clinical care. So now we'll pivot to talk about uterine serous carcinoma, which was first described as a distinct entity in 1982 in this paper from the American Journal of Surgical Pathologists by Dr. Kempson and colleagues. And what they did in this study was they took 256 stage 1 endometrial tumors and found a subset of 26 cases within these that had a higher degree of cytolytic atypia, papillary configuration, deep myometrial invasion, a greater percentage with LVI, and a higher relapse rate compared to other stage 1 uterine carcinomas. And the authors highlighted similarities with ovarian serous carcinoma, including distant spread and poor prognosis. So these are original figures from this paper. On the left, they emphasize the papillary configuration of some of these tumors, and on the right, the bizarre nuclear atypia, which is noted in some of these cases. So now we'll review histology of uterine serous carcinoma. Papillary growth pattern, which was originally, that word was originally, sorry. Oh, okay. Okay, I think someone. Sorry, okay. So these papillary growth pattern, as noted here, is present in about half the cases, and the papillae can be either thick or thin. The tumor can show glandular formation, or it can be solid. Marked atypia is a hallmark feature with characteristic vesicular nuclei with red nucleoli. Multinucleated or bizarre cells, which you can see here, are noted in about half of the cases. Mitotic activity is usually conspicuous. And serous carcinoma should be suspected in cases where there's abundant glandular morphology noted in conjunction with outsized nuclear atypia. So the histologic criteria, according to the 2020 WHO, notes that it has to have a cytologically high-grade endometrial carcinoma with complex papillary or glandular architecture, and it's desirable if you can demonstrate an abnormal P53 IHC pattern and diffuse P16 expression. And they define P53 abnormal as either diffuse strong nuclear expression or complete absence of nuclear staining or cytoplasmic expression. If it's mixed with another tumor type, which is most commonly happens with endometrioid, any component of serous should be reported as it impacts prognosis. This is an example of an abnormal P53 pattern on the left with diffuse nuclear expression of P53. And on the right, This is another helpful marker with diffuse expression of P16. So now we'll talk about the associated intraepithelial lesion, SEIC. So the surrounding and background endometrium in USC cases is most frequently atrophic, but in 90% of cases, the surrounding endometrium will show EIC, which is composed of one to several layers of cells with marked atypia, which really recapitulate that which you see in the serous carcinoma, including increased nuclear to cytoplasmic ratios, macronucleoli, and increased mitotic activity. This often happens on the surface of polyps, as demonstrated here, and would show abnormal P53 staining with diffuse overexpression in this case. Uterine serous carcinoma shows a propensity for lymph vascular space invasion, and the overall prognosis is poor, with worse findings noted in patients who are at advanced stage, greater than 60, have LVI, or greater than 50% myometrial invasion. Treatment typically includes surgical resection with hysterectomy and BSO, pelvic cytology, staging, pelvic and para-aortic lymph node dissections, and the standard of care is to treat these patients with chemotherapy with or without radiation therapy. It's not uncommon to find distant spread of disease in the absence of myometrial invasion. This is the NCCN guidelines for treatment of endometrial cancers with a serous component, which all include systemic therapy, which I have highlighted with the ovals. Recently, treatment with anti-HER2 agents has been added to the treatment algorithm, and now I'll pivot back in time to talk about HER2 and how this came to be. So HER2 is a tyrosine kinase receptor that is present on the cell surface. It's a member of the ERBB protein family. The gene which encodes this protein is also known by many other names. I'm going to most typically refer to it as HER2. It's located on the long arm of chromosome 17 at position 12. Each receptor has three domains: extra, transmembrane, and intracellular. Normally, these receptors dimerize when a ligand binds, which then activates signal pathways inside the cell. And I've put an example of pathways that can be activated by the Her-2 receptor. It's expressed in a variety of tissues and mediates proliferation, differentiation, and apoptosis. And in abnormal states, overexpression leads to ligand-independent dimer formation and constitutive activation, which leads to increased cellular proliferation. There are four members of the Her family of receptors. Her2 has no known ligand, but instead dimerizes with other members of the family of receptors when ligands bind. Since its implication in tumorigenesis of the breast, it has been shown to be overexpressed in tumors in various parts of the body, including USC. Now we'll go on a travel through a timeline to talk about important moments along the way in HER2. So in 1987, HER2 was implicated in breast cancer. This is the original paper from 1987 by Slayman and colleagues, which was published in Science. It was this paper that showed that HER2 was a gene of interest amidst the search for genes which were leading to cancer. This is an example of the southern blot analysis from that paper, which showed the result of denatured DNA, which was hybridized with HER2 binding probes. This is an example case which is highlighted, which had more than 20 copies. The conclusions of this paper was that HER2 was present at high levels in about 30% of breast cancers, and that high levels of HER2 were linked to a greater likelihood of metastasis and relapse and an overall decrease in patient survival. So following the publication of this paper, HER2 started to be investigated in endometrial cancers. Numerous studies were performed during this time period to determine whether HER2 was overexpressed. I will highlight one study from 1995 to show an example of the results. So this is a paper from Pisani and colleagues from 1995. They picked 104 cases which were sorted of endometrial cancer and sorted them into low and high grade histologic types by cytomorphology, which were assessed for HER2 and P53 by IHC. HER2 was scored on a scale of 0 to 3, and P53 was either scored as present or absent. P53 was correlated with overall survival, and while HER2 showed a similar trend, it was not significant. This paper highlights the limitations of many of the early studies, which included conflicting results overall regarding HER2 and outcomes, unclear numbers of serous cases, and mixed methods of scoring, and results of the scoring were not often given by tumor type. So following this, in 1998, trastuzumab, which the brand name is Herceptin, was approved to treat metastatic HER2 positive breast cancer. Following that, Her-2 started to emerge specifically in uterine serous carcinoma. So this is a chart of some of the studies which were published in this time, and I will highlight one study from 2004 to illustrate the trend in methods and findings during this time. So this is a paper by Slomovitz and colleagues, and they had 68 cases of uterine serous carcinoma. Positive staining was defined as diffuse and membranous and greater than 10%, so either 2 or 3+, and positive cases had FISH performed. 18 cases were positive by IHC, but only 2 of these were amplified by FISH. And HER2 overexpression was associated with a poor overall survival. So in this time period, HER2 was emerging as expressed and amplified in serous carcinoma. Results correlating amplification and expression were mixed, and scoring methods were not uniform, and the tumor types were still somewhat murky. So from about 2005 to 2014, HER2 was clearly associated with uterine serous carcinoma, and the number of studies in this era exploded with further clarification of tumor types and more refined scoring techniques. And there were still somewhat mixed findings with regards to outcomes. I will focus on one paper from 2013 by Buza and colleagues. They had 17 cases of HER2 positive uterine serous carcinoma with known heterogeneity. And 15 were pure, and 2 were mixed with endometrioid. IHC was assessed for heterogeneity by at least a 2-fold change, so either 0 to 2, 1 to 3, or 0 to 3, in 5% of the tumor using the 2007 ASCO and CAP criteria. So they had 8 cases which were equivocal by IHC, so 2+, and 9 cases which were 3+. 10 of the 14 cases showed cluster pattern of amplification, and these are 2 terms within the paper, and this isolated cell amplification as well, which were termed negative. So of these 14, 2 had a score of 2+, which initially were called non-amplified on FISH testing and were found to be amplified when repeated on a larger area. So really they were trying to examine what happens in these heterogeneous cases when you go to a broader area to do the confirmatory testing. This is an example of heterogeneous staining noted in some cases with the arrows, with the accompanying amplification of HER2 by FISH. The overall theme of this era, which had so many excellent papers, was that HER2 is clearly expressed and amplified in serous carcinoma. The IHC pattern is heterogeneous. The application of the scoring systems, however, was still not uniform, but there was an overall trend toward cases with HER2 having worse outcomes. So in 2018, Fader and colleagues published the results of a trial which showed benefit for these patients when treating with anti-HER2 agents. But before we discuss that, we'll take a brief diversion to discuss HER2 scoring. Definitions of positive, equivocal, and negative have changed since HER2 was approved. There have been 3 major releases of scoring criteria here in the US, 2007, 2013, and 2018. So HER2 IHC scoring actually has a very interesting story behind it. In 2007, an expert panel met to review the literature and practices around scoring. It was known that HER2 amplification occurred in about 20% of breast cancers, but overexpression of HER2 is associated, and it was associated with relevant clinical outcomes in patients. But the medication used to treat HER2 positive tumors, trastuzumab, was known to cause serious side effects in patients, including cardiac toxicity, and was very expensive. It could cost up to $110,000. So they knew that prospective sub-studies of adjuvant randomized trials demonstrated that as many as 15 to 20% of the HER2 assays performed in the field, so they mean in routine clinical practice, may be incorrect when the same specimen was reevaluated by a high volume central laboratory. So the resulting scoring system created uniform pathologic assessment, reporting, and testing of HER2, and also required labs which scored HER2 to participate in proficiency testing. So this is a schematic of the various scoring schemes for breast carcinoma from 2007, and we'll fill in the others as we go. The initial guidelines from 2007 created the threshold of positivity for 30%, uniform positive membranous staining in the invasive tumor. If incomplete membranous staining was noted and was weak or moderate in greater than 10% of the cells, it was scored as a 2+. Weak incomplete membranous staining in any proportion or complete in less than 10 was 1+, and negative here was no staining in this conception. In 2013, the update committee decided to revert to the previously used IHC criteria of more than 10% of cells being positive, which is noted here at the arrow, which actually was used as an entry criteria for the original studies of eligibility for adjuvant trastuzumab. But they also moved what was considered negative in 2007 over here to the equivocal category, which subjected these patients to additional testing with FISH. So the 2018 criteria mostly had to do with interpretation of FISH testing, and management of equivocal results in that area. I've put all the FISH testing, these are the scoring criteria for 2007, 13, and 18 here on one chart. A significant change was lowering the ratio from 2.2 to 2 in 2013. And the current guidelines, you see, group them in into multiple groups here, and you have to correlate it with the IHC. But the overall trend in scoring Her-2 was that the threshold to call patients positive was lowered, and they refined that equivocal category with an emphasis on additional testing through FISH. Though breast cancer has led the way in terms of Her-2 testing and targeted therapy, in gastric cancer, the first set of specific Her-2 testing guidelines was developed using the patient selecting criteria for the TOGA trial, which stood for trastuzumab for gastric cancer, as the basic framework, and highlights the differences from breast cancer. So these were used to make consensus guidelines, which are summarized here. Unlike in breast cancer, there's different scoring criteria for the surgical specimen versus the biopsy specimen, which highlights, which is in part due to heterogeneity, which is common. It occurs in about 50% of gastric carcinomas. And the tumor cells often show a U-shaped or basolateral/lateral membrane staining pattern, which is also incorporated into these scoring guidelines. So now we'll turn back to the story of USC. In 2018, this paper was published, and an updated version of the study was published in 2020. So you'll see the original results in white and the updated results in gold as we go forward. So this was a multi-center randomized phase 2 trial, which compared carboplatin and paclitaxel with and without trastuzumab. A prior study from 2011 had investigated single agent trastuzumab in advanced stage endometrial cancer patient and showed no benefit. That study actually had several problems. Among them were that endometrioid subtypes were included in the study. Also, they had mixed methods in terms of requiring FISH testing versus IHC for their inclusion criteria. This 2018 study had 61 patients with USC who had either stage 3 or 4 or recurrent Her-2 positive cancer. The tumors were centrally reviewed for Her-2 positivity and confirmed to contain at least 10% USC by 2 GYN pathologists. They used the 2007 scoring guidelines, and the Her-2 positive USC was defined by an immunohistochemical score of 3+ or 2+ with gene amplification confirmed by FISH. In all patients, the median progression-free survival was 8 months versus 12.6 months in the experimental arm. And these are the updated numbers, which were very similar. In stage 3 or 4 patients, the control was 9.3 months versus 17.9 months in the experimental arm, which was also very similar. And in the recurrent patients, it was 6 months versus 9.2 months. Additional findings of the updated study showed that overall survival was higher in the treatment compared to the control arm at 29.6 versus 24.4 months. And the benefit was most notable in those with stage 3 to 4 disease. So the conclusion was that addition of trastuzumab to carboplatin and paclitaxel was well tolerated and increased progression-free survival. And then in the additional study, also increased overall survival with that marked difference noted in those with stage 3 or 4 disease. So it was this study that led to the change in the NCCN guidelines, which now differ for those patients with Her-2 positive USC. Additionally, because I knew there were going to be so many clinicians in the audience today, I wanted to mention these other studies which are coming out, and these are ongoing. The results have been shared in some preliminary fashion and some recently published that showed that in some patients with USC, adding not only anti-Her-2 agents, but also multi-kinase inhibitors is showing promise for additional benefit. These studies are ongoing, and it's promising for these patients who have been traditionally resistant to conventional therapy. So now we'll pivot to talk about some work that I have published in this area. I would like to thank all of the folks at Johns Hopkins who I worked with on this project, including my senior author, Dr. Chimino Matthews. This paper came out in the American Journal of Surgical Pathology this year. So in our study, we looked at 85 cases of USC and SCIC from 1987 to 2011. We had 35 cases of SCIC, 47 primary USC, and 3 metastatic patients. 17 of these were from patients who had matched SCIC and USC, and we did IHC and FISH on all cases. We used the 2013 scoring criteria, and we also used the GE junction scoring criteria to compare the two. We also did FISH on all of the cases using the 2013 guidelines. Overall, 23% of our cases were either positive by IHC or FISH. There was no correlation between Her-2 status of either the SCIC or USC component and the clinical stage at presentation. The Her-2 labeling pattern was extremely heterogeneous within the majority of the lesions examined, with homogeneous staining noted in only 2 of the invasive tumors. So of the invasive cases by IHC, only 9% were positive, and that's contrasted to 19% were amplified by FISH. 40% of the invasive cases were equivocal by IHC, whereas only 12% were equivocal by FISH, and 51% were negative by IHC, and 72% were non-amplified by FISH. So this is an example of a case of USC with a homogeneous, strong staining pattern, which was the less common pattern. This is an example of the more common heterogeneous staining pattern. Importantly, breast and GI IHC scoring criteria performed equally. And for the invasive tumors compared to IHC, FISH was better able to discriminate between positive and negative cases, as only 5 cases were equivocal. A quarter of the invasive cases classified as Her-2 negative or positive with the breast or GI criteria were discordant by FISH. So 13 to 14% of IHC negative cases were amplified by FISH, and half of the IHC positive cases were FISH negative. Regarding the SCIC, the majority were negative. The remaining cases were equivocal by IHC. However, 7% and 4% of the SCIC classified as Her-2 negative with breast or GIHC criteria were discordant with FISH and were classified as Her-2 amplified. In total, all Her-2 positive SCIC cases were identified by FISH, and no cases were positive by IHC. So there were 15 cases with sufficient material for evaluation of both the SCIC and USC in the same patient. Importantly, 4 cases showed FISH discrepancy between the invasive and SCIC components. Another common pattern by IHC was equivocal scoring in one component and negative scoring in the other. 2 of these cases were negative in both components by FISH. 1 was positive in both components by FISH, and the other 2 had mixed findings. This is a case of SCIC at the top. So this is the in situ component here with the invasive component underneath it. And you can see that it's 1+ on IHC here, which would be considered negative, and the underlying carcinoma is positive. This is a separate case which was negative for overexpression by FISH in both the SCIC components on the left. This is the in situ component, and this is the invasive component with a Her-2 combined ratio of 1.02 and 1.66 respectively. So overall, we found that USC displayed Her-2 intratumoral heterogeneity, high IHC and FISH discordant rates, and a variation in Her-2 status between the SCIC and invasive components. Caution was required when evaluating Her-2 in small biopsies, which should be repeated on excision. And both IHC and FISH should be performed on USC until clinical trials correlate Her-2 status with clinical response to Her-2 targeted therapy. So now I'll pivot to talk about 2020 and where we are now with Her-2 and uterine serous carcinoma. And these are the questions we're hearing a lot from our clinicians. So which patients should we test? How should we score? What specimens should we test? And what tests should we use? So we'll march through all 4 of these questions. First, we'll ask who should we test? So we know Her-2 is expressed in some other gynecologic malignancies. However, there's no clear beneficial role of testing in things like vulvar Paget's disease or ovarian neoplasms, including high-grade serous carcinoma of the ovary. Interestingly, Her-2 is emerging in carcinosarcomas. Studies have shown increased expression in the epithelial component of uterine carcinosarcoma. These tend to be serous or mixed histotypes, but there are no formal trials evaluating HER2 in this setting with published results. This is an example of a figure from Rotman and colleagues' paper in 2020 in Modern Pathology, and you can see the epithelial component of the carcinosarcoma at the top portion, which is overexpressed by IHC, and the cartilaginous or sarcomatous component is showing equivocal staining there. So requests for testing are increasing. Which patients should we test? I think there's a clear role for testing in uterine serous carcinomas and a good argument for uterine carcinosarcomas, especially those with a serous component, but most of the time that's on a case-by-case basis, at least at the institutions that I'm familiar with. So now we'll talk about how should we score. Buza and colleagues, who are real thought leaders in this area, have proposed this new uterine serous carcinoma specific scoring criteria. This came out in Archives of Pathology and Lab Medicine in 2020. Review of their scoring criteria shows it approximates the 2007 breast criteria in terms of percentages for cutoffs, with incorporation of the basolateral and lateral staining pattern that has been noted in some GE junction tumors. And additionally, when we're talking about how to score, Buza and colleagues also published this paper in 2020 where they showed using digital slides and sharing them with folks at many different institutions that the overall concordance rate of HER2 score was 70% between the gastric and breast criteria, and the authors proposed scoring criteria also for carcinosarcoma that encompasses basolateral staining patterns. So requests for testing are increasing. How should we score? Recommendations exist, but no formal uterine serous specific guidelines. The College of American Pathologists, which pathologists in the United States use, still cites the breast criteria to use to score uterine serous carcinoma. The the International Cancer Consortium guidelines do mention Dr. Buza's paper from 2020. However, there are no formal recommendations that I found. So what specimens should we be testing? This is a paper also from Rotman and Buza and colleagues, where they looked at which types of specimens and the concordance. So they had 57 patients, 14 of them, so 25% were HER2 positive, and they had 40 paired hysterectomies with biopsies, and FISH was performed on equivocal cases. So they had 37 cases scored, and 31 were concordant between the biopsy and the hysterectomy. Of the 6 discordant cases, there were 2 which were negative on biopsy and then were positive on the hysterectomy. And that it was more common to have positivity on the biopsy with negativity in the hysterectomy. And heterogeneity was noted in over half of the tumors. So when we talk about what specimens to test, there are several problems in this area, including there's no uniform fixation, especially for hysterectomies. Tumoral heterogeneity and specimen size can make testing of only biopsy samples problematic. And the role of testing in metastatic disease is ongoing, but early studies show there is also discordance in about 20% of cases between the original specimen and the metastatic disease. So, hindering the research in this area is that studies are hard to perform because this tumor is rare, especially compared to breast. So for now, I think it's prudent to test biopsies and resection specimens, especially if your biopsy specimen is negative, and also in patients where therapeutic benefit could be seen, also new metastatic disease. So now we'll talk about what tests to use. In breast cancer, FISH and IHC are equally predictive of clinical response. So either IHC or FISH is acceptable as first-line testing. In gastric carcinoma, protein expression showed the strongest association with clinical response. So IHC is the primary test there, with FISH used as the reflex. And regarding heterogeneity, in breast and gastric cancer, patients with tumoral heterogeneity showed less benefit from targeted therapy. And most published studies on uterine serous carcinoma have used IHC upfront with reflex testing on equivocal cases. However, in our study, we demonstrated that there were high rates of discordance, which indicates a role for FISH testing not only in equivocal, but also in negative cases, possibly. So what tests should we be using? I think it's reasonable to use IHC upfront with FISH testing on at least all equivocal tumors. and possibly on negative cases in biopsies and those with tumoral heterogeneity. In conclusion, uterine serous carcinoma is an uncommon but aggressive variant of endometrial cancer. Targeted therapy is promising. Testing for HER2 will likely increase in the primary and recurrent setting for USC, and the role of HER2 testing in other gynecologic malignancies is still unclear and not routinely performed. Breast criteria are being utilized for HER2 analysis, with additional scoring criteria being proposed. Known tumoral heterogeneity likely limits the utility of breast criteria. There is discordance between SEIC and USC in the same patient and in biopsy and resection specimens. And when testing, it's better to err on the side of repeating or doing it on multiple methods until better and more clear guidelines exist. So that's all I have for now. I'm happy to take any questions. Thank you so much for having me.
Okay, thank you, Dr. Banet. That was a wonderful presentation. Remember, everyone, you can still post your questions on the chat. Meanwhile, we do have some other questions. So, Dr. Banet, we wanted to know, I know you just said, like in the conclusion, some of this, but just to point out, due to heterogeneity and costs and the current approved therapies, would you recommend to test HER2 at the diagnosis for all cases or only for advanced stage 3, 4 or metastatic and recurrent specimens?
That's a really good question. So you're talking about like stage 1 and stage 2 patients.
Yeah.
You know, I always find that it's easier to do testing at the time of diagnosis than to try to go back and do it, right? But I realize that you have to think about cost, especially in places where, maybe the resources aren't as abundant as some other places. But I always find it's better to do it up front than to try to find that block later and to go back and do the testing. The other thing is, we know that it's always better to do the test closer. I mean, the specimens maintain themselves in paraffin well. The other thing is, for breast cancer, we are doing all these tests up front. So when people are talking about cost, at least here in the United States, when someone's diagnosed with breast cancer, we automatically do ER, PR, and HER2 on all patients. And we know we're doing that on, low-grade breast cancers, stage 1 breast cancers, patients that are not going to get that therapy. But then the clinicians have that data point for later. Should something happen with that patient down the line, you can compare the results. And I just think it's better to do it if you can initially, because you never know what's going to happen in the future. But especially since this tumor is so aggressive and it really does stratify them into a whole different treatment algorithm.
Okay, great. This is not like from the uterine carcinoma, but they're asking if, do you currently test HER2 for other types of endometrial carcinoma?
We don't. And I don't see the request so much for other types of uterine carcinoma. I suppose there would be some temptation to talk about doing it maybe in other P53 positive endometrial cancers. And I think people are looking at this and people are doing research on it. But I think right now we don't know enough about what that means in the context of, there's no clinical trials and that kind of thing. I do see clinicians asking for it in ovarian serous carcinoma. And a lot of times I would have a discussion with clinician about why they're wanting this and making sure, that it's clear where the tumor originated, and that as far as I know, there are no clinical trials evaluating HER2 and showing clinical benefit in ovarian cancer. So.
Okay, great. Okay, here we got, are there mechanisms to lower the risk of false negative results for HER2 overexpression due to intratumor heterogeneity?
That's a good question. Yes, I think there are. I would be remiss to say that, the fixation problems, you can tell from that paper that Buza published about the fact that the biopsies were less likely to be false negatives. And that's probably because most clinicians are taking the biopsies and putting them into formalin as soon as they take them. So we know that that's one thing, the cold ischemic time, right? And hysterectomies have very variable cold ischemic times, probably depending on the time of day of the surgery and the time that, a pathologist or someone who evaluates the specimens can get them into formalin. But So certainly if you know that that's the case, you could try to get it into formalin quicker. And then with the specifically addressing heterogeneity, I think it's better to evaluate these on whole sections. So probably doing it on the section that has the most tumor to make sure you're really getting a good idea of what the whole tumor looks like. And if you're doing it on a small biopsy, then to go ahead and repeat it if it's negative on the resection specimen for sure.
Okay, great. Okay, we have another question over here. In breast cancer, HER2 overexpression in the absence of amplification is stated like a rare event, and it's mostly considered by some like a false positive, but some argue that it can be due to upregulation of HER2 in the messenger RNA.
Mm-hmm.
So I wanted to know if this phenomenon has been studied for uterine serous carcinoma, and do data differ from those in breast cancer?
I don't know of studies which have addressed that question specifically. I'm familiar with what you're talking about in terms of interpreting that as a false negative, but what we do know is those patients who have overexpression without amplification still benefit from anti-HER2 agents, right? So we know something's happening with HER2. And so that's another thing. And a lot of the times what we run into with uterine serous carcinoma is we just don't, and when you look at the breast cancer patients, the studies, they have like 8,000 patients, you know, and we looked at a large academic medical center for 30 years and we found 60 cases. So these are just, it's insufferably difficult to find enough to do that kind of study, but that's a really interesting point. Yeah.
Okay, and so even if you found in one case, like you did the immunohistochemical method, and you also do FISH, and you have like 3+ in immunohistochemistry, and the FISH is negative, so it would be indicated to give them therapy, yeah?
According to the original trial with Fader, yeah, they would not have even fished that case, right?
Yeah.
If it was 3+, they would have just treated that patient. So yes, they would have gotten therapy, and certainly those patients showed a benefit. So it would be interesting to go back and retest those specimens to see if any of them really were FISH negative. But
yeah.
Yeah.
Okay.
Yeah.
And in that same line, so as for clinical practice, as you said, it would be better always to do first immunohistochemistry and then go to FISH only if it's equivocal, right?
Well, the reason I said that is because I think most labs, it's easier to perform IHC, right? Because to do FISH testing, you have to have a dark field microscope. You have to have cytotechnologists usually who are specially trained in that, unless you're doing something like chromogenic FISH, which I have done before. And it's actually, I don't know if you all are doing that where you are, but I found that it was extremely difficult, like analytically, to get it done correctly. And then to interpret it wasn't hard, but to make sure that the specimen was quality and that it was quality performed, it's not as easy as doing IHC. So the reason I say to do IHC first is because most people have immunohistochemical labs. So it's a reasonable place to start. Yeah, for sure.
Okay, yeah, and on the chromogenic in situ hybridization, we also had like this question because there has been some authors that describe it's a valuable tool, and they also say it's cheaper. So I don't know, like
it probably is cheaper because you're using the same instrument, basically a light microscope, to interpret it that you use to do IHC. But like I said, it's technically difficult because it's got multiple. You know, you have to do multiple hybridizations on the same slide, and it's just it's technically finicky, I should say, difficult. Yeah.
Okay, great. Well, I have another question, but I think you already talked about that. If you would recommend to test on curettage sample or in surgical specimen, or in both, if you can.
Yeah, I certainly think testing on especially since on a biopsy specimen, you never know if that patient's going to make it to hysterectomy, right? Like maybe they'll have a problem, they won't be able to have surgery. And we know that probably the quality, like the ischemic time is probably shorter. So testing in that scenario is clearly appropriate. But if you have a negative test in that, I wouldn't then not retest the hysterectomy if I could. Yeah.
Okay, great. Okay, I don't seem to have some other questions. I don't know if someone wants to speak up and we could translate if someone has a question they want to do, because I don't see like further questions here. No. So I believe that's it. Dr. Banet, that was a great conference. Thank you. Like you highlighted the most important aspects. I think it was very clear for everybody. Like, what do we have to do right now? And of course, we will be waiting on further evidence, right? And then we should know if we should use the same criteria or if we should change. Yeah. Oh, yeah. There's another thing I wanted to know. If you think that maybe for endometrial cancers, we should have also different criteria for the biopsy specimen and for the surgical specimen, as in the GI criteria that you showed in your slides.
Yeah, and the thing is, I worked in a practice where I was scoring GI cancers, and my impression of the reason that they did have different criteria was to have a lower threshold to send those cases for FISH. So I think what they were trying to do was basically make it lower, like in the biopsy specimen, basically any aberrant staining, you could send it for FISH. So what they were trying to do was not miss any patients. So I certainly think that could be reasonable, but right now I think uterine serous carcinoma is still so unknown and so wide open. I think we need more cases and we need to study more, because even GE junction cancer is way more common than uterine serous carcinoma. That's a really good question. Thank you.
Okay, yeah, no, thank you. That's like all the questions I have for the presentation. Lovely to meet you.
Yeah, the same. Thank you all so much for having me. It was a pleasure.
Okay, thank you. Thank you, Dr. Natalie Banet, y thank you, Angélica. Muchas gracias a todos por asistir. Muchas gracias a la doctora Banet por habernos ilustrado y con una conferencia muy, muy interesante. Antes de despedirnos, quiero recordarles que el 17 de noviembre a esta misma hora tendremos un webinar también muy interesante con la doctora Jennifer Bennett de Estados Unidos, y hablará de actualización en tumores uterinos mesenquimales. Para que por favor se programen desde ya, les estaremos recordando para que se inscriban. Y nuevamente, Angélica, muchísimas gracias por tu participación, fue excelente y le hiciste muchas preguntas muy interesantes. Doctora Natalie, muy agradecidos. We're very, very pleased to have had you and very honored. Thank you again.
Thank you.
Bueno,
have a lovely
si
night.
no hay más preguntas, nos despedimos. Muchísimas gracias a todos por asistir.
Vale, buena noche. Bye.
Chao.